Achilles, if I squeeze her calf, what should happen to her foot? Yep, and we see that happening. If we do that, and it doesn't plantar flex, then something's missing there, right? This has to be effective. It would have to be like a total rupture. Right? If it's just a partial rupture, you'll still probably see some movement with that. Nice on an Achilles that you can actually palpate the tendon pretty well. And so palpating along the borders of the tendon and actually feeling, do you feel nice, smooth borders, or is there a little gap? And it feels pretty much like what you would expect to feel if there was a tear in, you know, like a rope or something, where there's a little bit of a notch there. But places, even though it's an excessive tension injury like we talked about, some of the underlying mechanism is actually excessive compression. And so people that have like tight shoes on the back of their foot. So tendons are made up of what type of cells we talked about last year that make collagen? What are the cells that handle collagen? Tenocytes, yeah, are collagen fibrils for the tendon that are longitudinally aligned. Tenocytes and fibroblasts make the collagen. So they're able to handle tensile loads. They're designed to do that. If you compress on them, they're not able to handle that, and so it actually causes breakdown. Happens in the shoulder too, right? So we think about shoulder impingement syndrome, and it leads to tendinopathies in the rotator cuff. Basically with this is the person that when they go into deep dorsiflexion, they'll feel pain across the anterior part of the ankle. And so it's called an impingement because one of the things that happens there is that the capsule around the talocrural joint can actually get pinched between the talus and the tibia when they go into deep dorsiflexion. So what types of activities would someone go into deep dorsiflexion? Yep, squatting down, that's a good one. Put your thumb on the anterior, right where the tibia and the talus come together on the lateral side is where that's showing. The idea is the same. You're trying to push the capsule into the joint space and then compress it. Dorsiflexion, force dorsiflexing the foot to see if we can reproduce that pain. If I could reproduce it with my thumb there, like pushing the capsule in and impinging, then it's more likely to be the capsule. And if I do it and it's not painful, so if it's not painful when I just dorsiflex and it's painful when I impinge, it's probably capsule. If it's painful when I do both, then it really could be either one. You can't. That's not a good way to tease it out. But you can at least tell if I put my thumb in, force dorsiflexion, pain, take the thumb away, kind of keep the capsule out, force dorsiflexion, not pain, then I'm more suspicious that it's the capsule that's. Personally, I like to hook 2 fingers under the heel, in some way get underneath the heel. Just make sure you stabilize the tibia there, and then just a quick anterior movement. And what are you feeling for a normal, healthy ligament? It's firm, really good abrupt stop. Damage to it, but it's not fully torn. What do we say that kind of feels like? Crepitus? A spongy or kind of a boggy. It doesn't have that nice crisp infill to it, that hard infill. And then if it's totally ruptured, then what does that feel like? Yeah, you got just lots of movement there. You do these off the end of the table, fibula. Yep, fibula, calcaneal fibular ligament. So if we think about keeping the foot kind of in a neutral position and tilting the talus medially, we're putting stress on that ligament. So that's the test for that. Sides, we have the big deltoid ligament, but same sort of thing. Tilt the calcaneus laterally, stabilizing the tibia, and putting stress through the deltoid ligament. Compressing on the fibula, compressing the tibia and fibula together above the level of the syndesmosis, and reproduction of pain. So that would be, and the pain would be down distal around where the syndesmosis would be, and so that would be an indication of the pain. or a high ankle sprain. This nerve entrapment test. Remember the tarsal tunnel coming through. So on the medial side, wrapping underneath the medial malleolus, tibial nerve, and the distal ends of the tibial nerve coming through here. So this is with tarsal tunnel syndrome. So one of the things that happens is numbness, tingling, paresthesias in the medial foot, kind of the medial plantar side of the foot. This nerve that's really sensitive, and this is where the problem is coming from, is you're going to put tension on the nerve first. So if I wanted to put tension on the nerve, I'm going to evert the foot and extend the toes. So I'm tensing the nerve through the tarsal tunnel. And if that's not enough to reproduce your symptoms, that's also do a Tinel's right over the carpal tunnel. Tinel's is just tapping without doing the eversion, and then we just added it all together. Distal tib fib. There's not a specific, like I do an anterior glide for dorsiflexion or a posterior glide for plantar flexion. It's not specific for the tib fib. What you want to see that there's a good amount of glide to go there. If there is in both directions, then that means there's enough slack for it to widen. So if there's not, then you're going to do either an anterior glide or a posterior glide, depending on which one is not as mobile. So if we're going to do a posterior glide of the fibula, what's my direction of force? Medial.
Damn it.
If the talus is wider anterior, and this is kind of how you think about it, the talus is wider anterior than posterior, right? So that means that my fibula is gliding along a joint that's like this, right? It's more narrow posterior, more wide anterior. So it has to glide along the tibia posteriorly, which means I'm basically kind of pulling the Achilles out of the way a little bit and using my fingertips and my hand to block the tibia. So I got a good grip on the tibia. Come down just a little bit. So I don't want her heel blocking there because I want to get my hand down on the bed. And then I'm going to take my thenar eminence, put it right over the fibula, get my forearm in line. So I'm going posterior and medial, good. And I'm just leaning in for my mobilization. And you can kind of play a little bit, find that joint line, fiddle around. Where's the most movement? Okay, right there. So I know my glide's going to go this way. So that you're not blocking the fibula with the wedge, just like I did with my fingertips holding the tibia. Block the tibia with the edge of the wedge. Hold the foot down. Posterior, medial glide. So I'm going to again take my fingers. I'm going to block the tibia with my fingertips. Lock down into the bed. I'm taking up all the slack. Get on the posterior aspect of the fibula. Anterior and lateral glide. Here. Anterior, lateral. Okay? I'm going to take that. I'm going to put my fingertips under the lateral malleolus. Put my thenar eminence under the medial malleolus. So I've got her tibia and fibula locked in. Lock that down on the table. So now as I push her foot down, I'm catching her fibula, I'm catching her tibia. I'm taking all the slack out of the table. Her lower leg's not going anywhere. I can really get in, get my forearm in line, lock, and do an Oompa Loompa. Bend your knees, really squat down into it.
You're also pushing caudally, right?
Mm-hmm.
Inferior caudal.
Yep. Same thing for the anterior glide. I'm going to do the same grip. Hook under the medial lateral malleolus. Put up a little bit. Come in, lock down on the table. Get my forearm in line. Anterior and a little bit inferior. And then lean and do an Oompa Loompa. If you're doing the anterior glide, you can just block the tibia and the fibula with the edge of the wedge here. If you're doing a posterior glide, you could actually use the little groove, which becomes like my hand. Right? Yes, when you're doing a mobilization, you can never pull hard enough for things like this, for like big joints like this. When we get into feet, no matter where we are on the foot, if we're on the medial side, or even if we're out here on the lateral side, like doing things like the cuboid, your line of force is always perpendicular to the arch of the foot. Wherever you are, just make sure your glide is perpendicular to the arch at that point, and you'll be. So we did talocrural. It's down here. Talonavicular, yep. So talonavicular. So if we want to do talonavicular mobilization, it's nice to use the wedges. With the wedges, don't necessarily try to get like the edge of the wedge blocking on the foot, because you have this big gap here. Use the wedge as a way to kind of take up space and orient the foot, and still use your fingers as the actual block. So I'm going to come in, so the head of the talus is here, so I'm going to hold underneath the talus, thank you. And then I'm going to use the wedge as kind of my block there. Right? Got the talus locked down between my fingers. And now instead of when we did the assessment, remember we used kind of a pinch grip, and we just assessed here going up and down. Now I'm going to use my first MCP, second MCP. I'm going to put it right over the navicular. Make sure I have the talus blocked. Get in line, so see my forearm is perpendicular to the arch of the foot. And then posterior glide. Joint line, find the plane of the joint for that particular person. You kind of know where you should start, but find the actual joint line. Good, right here. And now, bam, I'm going to go in and do my mobilization. All my force is going right through the first MCP here. As I go down, so that was navicular on the talus. So now what am I going to stabilize going down to the next joint? Grab the navicular, stabilize, first metatarsal, and find my joint line, fiddle a little bit, take up all the slack. I'm taking all the slack in the table, all the slack in her foot, do my mobilization. It's going right through the base of the first metatarsal. Cuboid's on the out here. Cuneiform, yeah, it's cuneiform. So I jumped a level, yeah. The cuboid's out here, cuneiform, so navicular cuneiform, and then the cuneiform metatarsal. Stabilizing, I'm holding with my hand. So starting out with the talus, then the navicular, then cuneiform. And then whenever I'm mobilizing, I'm pushing with the second MCP. Going right down the line. Okay. Dorsal glides, so flip over onto your stomach. Same idea. I'm going to start out, I'm going to block the talus. I'm going to be on the navicular, block talus, navicular. Now I've got to come out because her foot is here, so I still want to be perpendicular to that arch. So my line of force has to become kind of a little bit superior as I go in. And so oftentimes with the great toe, we'll just go ahead and pull the foot up here, because I can stabilize that first metatarsal really well. I can go into the amount of extension that's available, go to the battleground, and then do my glide.